Hi, I'm Dr. Scott Klein. I'm the Chief Medical Officer here at Blythedale Children's Hospital. Normally, we'd love to have you come in, and the best way to get to know Blythedale is to come and visit us. Unfortunately, nowadays we can't do that, so we're going to do the best we can through a virtual tour. Blythedale has 2 floors. Our first floor has 46 beds, and for the most part is actually all under the age of 1. What we have found is how that's come about is because of the real explosion in neonatal care and NICU care and kids coming to us for rehabilitation and trying to provide whatever acute services they still need. So let me walk you around and I'll show you some of our features. So for the babies that are coming here, especially from the NICU, coming here so early in their care, the ability for us to be able to provide acute medical services as well as rehabilitative services is really important. So for us to do that, we have to have capabilities that you'd expect somewhere beyond what a typical facility could do, maybe not as much as a NICU, but certainly enough to be able to continue to care for these children in a safe way. So with that, we have a pod structure here that allows us to have a mini unit where each of the rooms are in front of the nurse's station, which is important for the parents, and it allows us also to respond as quickly as possible if there's emergencies. We have a full RN staff. We have a medication area where the nurses can prepare their medications. And we have an on-site compounding pharmacy, which allows us to make infusions. We can do chemotherapy if needed. And especially for the kids coming to us with pulmonary hypertension, they can do infusions or other treatments that would be needed for those kinds of children. And we could do TPN as well. In order for us to be able to take care of these complex kids, we also have to have very significant medical services. And with that, we have a pediatrician in-house 24 hours a day. And then we have services taking care of those kids as you'd expect for their level of acuity. So we have full-time neonatology, we have neonatal fellows, pediatric pulmonology and pulmonary fellows, physiatry. We even have pediatric ophthalmology so that we could do ROP exams, again, trying to get the babies here as early as possible, continue their acute needs, but get them started on rehab. One of the big differentiators for a place like Blythedale is the ability, first of all, that we're piped in for gases at every bedside. So what that means is we don't have a ventilator unit or separate areas. We can put a ventilator at any bedside. So any of our 94 beds, we can have a ventilator going, and we're piped in for all the different gases. We do ICU ventilators, we do portable ventilators, and we do the newest portable ventilators that often have the capabilities of an ICU ventilator, but can be portable such that we are able to have the child no longer tethered to the wall and be able to participate in activities. Beyond that, we have all the monitoring that you'd expect for a facility like Blythedale, but even more given the fact the type of kids we have. We can do continuous pulse oximetry, we'll do end-tidal CO2, whatever is needed in order to be able to safely monitor the child and to be able to direct how we do monitoring and weaning. We can do other technologies, peritoneal dialysis, we do VAC systems, and we'll even do infant peritoneal dialysis and infant VAC as needed. A major contributor to our success here are our therapists. We have respiratory therapists that are here 24 hours a day that help us with management of the respiratory needs and weaning. And then we have over 85 physical, occupational, and speech therapists that are special in the sense that we consider ourselves tertiary rehabilitation, and they're able to do this caring for the most medically fragile of children. They're able to really work with kids on ventilators, work with kids with brain injury in a way that you would not normally see in an acute care hospital. Among the things we do with our feeding therapies is we have the ability to do fiber optic evaluation of swallowing here, which allows us to reduce the number of kids that need to go for a modified barium swallow, and allows us to track them over time as they progress in their feeding abilities. So one of the things that's really important about how our infants do in the long run is their neurodevelopment. So we work on ventilator weaning, we work on weaning their pulmonary hypertension medications, but in the end, we also have to make sure that the neurodevelopmental outcomes get us to where they want to be for their future. As a hospital that specializes in medically fragile children, rehabilitation for infants involves their ability to socialize and interact with other infants and really start working on normal infant development. So as you can see in our infant room, this footage obviously is pre-pandemic. We have the ability to have these infants come out of their rooms, go to a mat, and do what every other baby does, circle time. And so what you see here is our therapists working with these infants on a ventilator, on a feeding pump, on an IV pump, and they're actually able to play and socialize, and for the first time often see another infant. And what we have found and others have found is that the outcome for these children neurodevelopmentally is much better if they have that ability to interact with other infants. But even more importantly is what we do for parent training. So as you can see with a child on a ventilator in that room, in order for that child to get into the ventilator, get from the ventilator into the room, parents have to learn how to take their child from the crib, put them into a stroller, connect the ventilator, hook up the oxygen tank, set up the feeding pump, and then wheel them into the infant room, and then do all of that, get them set up on a mat. These are things they're going to do at home. But they get to learn this in an environment where they're with our staff, and they learn to do it safely and effectively. And in the end, it's creating not only skills for the parents, but giving them the confidence to be able to do this when they go home. As I mentioned, our clinical team taking care of these infants is made up of neonatology, neonatal fellows, pediatric pulmonology. And our doctor heading up this team is Dr. Dennis Davidson, who I'd like to show you now.
Thank you, Scott. My name is Dr. Dennis Davidson. I'm the unit chief for the infant toddler unit at Blythedale Children's Hospital. I've been in practice for 40 years. We get patients from all over the tri-state area and beyond. Now let's discuss the kind of patients that we do get here at Blythedale. The diagnoses we most frequently see fall into 4 different categories. The most common are babies who are born premature and subsequently have chronic lung disease, which requires ventilator support. This is also known as severe bronchopulmonary dysplasia. We are widely recognized as experts in ventilator weaning and providing specialized non-invasive respiratory therapy. This is something highly unique to Blythedale and that wouldn't be found at traditional post-acute children's hospitals. The second category of babies that we get are cardiac patients. Our multidisciplinary team provides the wraparound care to ensure they are in prime condition before heading back to the OR while continuing to get excellent developmental care. Babies are also referred to Blythedale for therapeutic feeding needs related to conditions including prematurity, short gut syndrome, brain injury, oral motor dysfunction, cardiac disorders, aversion behaviors, cognitive deficits, and post-surgical complications. Blythedale has extensive experience in enteral feeding, weaning infants and children from supplemental tube feedings, and decreasing the dependence on tube feedings, as well as giving the babies excellent feeding therapy with more than a dozen pediatric trained feeding specialists on site. We also treat babies that have brain injuries, often related to problems that occur at or around the time of birth. These babies are in a stage of brain development where it's critical that they not only get the best nutrition, but they get the right kind of stimulation in a developmentally appropriate environment. My treatment philosophy starts with the transfer of information from the referring hospital. I'm a stickler for getting details on patients to be sure that the transition from the intensive care unit to Blythedale is seamless, safe, and effective. While the baby is here, I keep my door open to my office, which is located right in the center of the floor, so that anytime therapists, nurses, or parents can come in to see and talk to me about their babies. Here, we are able to provide continuity of care that you don't see in an academic medical center with doctors rotating through. And that's critical in helping parents feel both safe and confident in their ability to care for their medically complex child. Our goal is to educate the family to safely care of the baby by the time the baby is ready to go home. This is done through extensive training, both bedside and in our simulation lab. I can understand that it's something very nerve-wracking for a parent, and one of our jobs at Blythedale is to ease their anxiety and help them become competent, confident caregivers. That's why our physicians, nurses, therapists, dietitians, social workers, and child life specialists play such a vital role. Because of the wide-ranging disorders and disease states that our babies present with, we are constantly on our toes to stay on the cutting edge of medicine. I think it's this deep commitment to getting our babies home to their families, in many cases for the first time for these infants, that compels us to do this work. Thank you for stopping by, and I hope to meet you in person someday.
Thank you, Dennis. As you can see, we are really proud of the work that we do here at Blythedale. We think that we can take care of the most complex of infants and provide both a great transition out of the ICU, providing their acute care needs that they still have, while starting rehabilitation early and giving them the best outcomes. By doing this, we're able to shorten ICU length of stay, help with throughput through the ICUs, and then get these children to an environment where not only can they thrive, but we really can work on parent training and get these children able to go home. I hope when things change, we're going to be able to have people come soon to come for in-person visits. But I hope, meanwhile, you've enjoyed your virtual tour, and I look forward to meeting you.